Welcome to the Deep Dive, your shortcut to critical knowledge. Today, we're tackling a really important area, the pharmacology from Chapter 43. We're talking antimalarial, antiprotozoal, and anthelmintic drugs.
Yeah, basically the drugs we use against parasites and worms, these tiny organisms that, well, live off us.
And our goal today is to really distill the core info you need, the must-knows, from your source material.
Exactly. And it's serious stuff. Protozoal infections like malaria, giardiasis, amoebiasis, they're huge global health issues, especially, in warmer, humid places.
But not just over there, right? The sources are clear. These are increasingly relevant here, too.
That's right. Think about international travel. It's so common now. Plus, we have more people who are immunocompromised, maybe with AIDS, for instance. So the risk of exposure here in the U.S., it's definitely growing.
So our mission for this deep dive is pretty clear. Get a handle on the main drug classes, figure out how they work your mechanisms,
Yeah, the MOA.
flag the big safety warnings, and nail down the nursing steps needed to manage these infections properly.
Okay, before we jump in, let's quickly define some terms, just to be on the same page. A parasite?
That's any organism living off a host, causing harm. Simple enough.
Right, and protozoans are a type of parasite, single-celled. The simplest kind of animal life, really. Malaria is caused by one.
Got it. And helminthic infections.
Worms, parasitic worm infections.
Okay. And one more clarification. Antimalarial drugs are technically a subgroup of the broader antiprotozoal category, specifically targeting Plasmodium.
Precisely. They zero in on the malaria parasite.
All right, let's dive into section 1, antimalarials. Because malaria, wow, it's still the biggest protozoal disease out there, impact-wise.
Huge numbers. The sources mention around 228 million infections globally each year. Yeah. Sub-Saharan Africa carries the heaviest burden, but also Southeast Asia, Latin America.
And it's caused by 4 main Plasmodium species, but there's one that's particularly troublesome.
Yeah, P. falciparum. That's the one really driving drug resistance problems, which makes treatment much trickier.
And transmission is mostly the mosquito bite, right? The female Anopheles mosquito.
Primarily, yes. Though, it can also happen through blood transfusions or congenitally from mother to child.
Now, the key for treatment seems to be understanding the parasite's life cycle in us. It's got 2 main phases.
That's critical. There's the exoerythrocytic phase. Think outside the red blood cell. This happens first in the tissues, mostly the liver. The parasite is kind of hiding out and multiplying there.
Okay, hiding in the liver.
And then there's the erythrocytic phase in the red blood cells. This is when they burst out into the bloodstream, and that's what causes the classic malaria symptoms.
Ah, the paroxysm. Describe that again. It sounds pretty dramatic.
It really is. It starts with intense chills, shaking rigors, then a high fever spikes, maybe up to 104 Fahrenheit, 40 Celsius.
Wow.
Followed by profuse sweating diaphoresis, and then just utter exhaustion. And this whole cycle tends to repeat every, say, 48 to 72 hours, depending on the species.
Okay, so how do our drugs fight this? Let's start with the older ones, chloroquine and hydroxychloroquine. They work on the blood stage.
Correct. They're effective during that erythrocytic phase. Their mechanism is pretty neat, actually. They get inside the parasite within the red blood cell and basically interfere with its food source.
Oh?
They inhibit DNA and RNA polymerase, but importantly, they also raise the internal pH inside the parasite's digestive vacuole. This stops it from breaking down hemoglobin properly. Essentially, you're messing with its digestion, starving it from the inside.
Starving it. I like that analogy. And hydroxychloroquine, that one pops up elsewhere in medicine too, doesn't it?
It certainly does. Because it also has significant anti-inflammatory effects, it's widely used for autoimmune conditions. Things like rheumatoid arthritis, systemic lupus erythematosus.
So same drug, different job entirely.
Sort of shows how complex these molecules can be, impacting both parasites and our own immune system.
Okay, but if chloroquine only hits the blood phase, what about that liver stage, the exoerythrocytic part?
Right, chloroquine won't touch that. For the tissue phase, you need something different. That's where primaquine comes in.
And why is primaquine so important?
It's one of the very few drugs we have that's effective in that tissue phase.
Yeah.
It's essential if you want a true cure, especially for vivax malaria, which can relapse from dormant liver forms.
And its mechanism, how does it kill the parasite in the liver?
It seems to work by binding directly to the parasite's DNA and altering it, preventing it from functioning properly. More direct damage.
Okay. Now what if we're up against that resistant P. falciparum?
Then we often reach for mefloquine. It's used for both treating active infections, including multi-drug resistant strains, and also for prevention, for prophylaxis.
Got it. Now, before we dig into specific side effects, there's a really critical dosing issue with these drugs that the sources highlight. Can you explain that? It sounds like a potential minefield.
It really is, and it causes a lot of confusion.
Yeah.
You absolutely have to pay attention to the labeling.
Yeah.
Often, the strength listed on the bottle, say 500 milligrams,
Yeah.
that refers to the weight of the entire drug salt compound. But the actual prescribed dose, the doctor's order, is usually based on the weight of the active base ingredient within that salt.
Oh, I see. So the 500 milligram tablet might not contain 500 milligrams of the part that actually fights the malaria.
Exactly. That 500 milligram salt tablet might only contain, for example, 300 milligrams of the active base. So if the order is for 300 milligram base, you give that one tablet. If you just saw 500 milligrams on the label and gave that based on an order for 500 milligram base, you'd be underdosing, or vice versa.
That is crucial. You have to know the base content of the specific formulation you're using.
Absolutely critical for safety and effectiveness. Double check every time.
Okay, with that vital point made, let's talk specific risks. Mefloquine has a black box warning.
Yes, the FDA mandates it. This is due to potentially serious neuropsychiatric side effects. We're talking about things like significant dizziness, anxiety, depression, even hallucinations or psychosis in some cases.
So who shouldn't take it?
It's absolutely contraindicated for anyone with a history of major psychiatric disorders, depression, generalized anxiety disorders, psychosis, schizophrenia, seizures. You need a thorough history check.
And what about chloroquine and hydroxychloroquine? Any specific watchouts there?
Yes, particularly vision changes. They can cause visual field defects, even optic neuritis. So baseline eye exams and monitoring are important, especially with long-term use like an RA.
Okay. And primaquine. You mentioned another risk earlier, something about a blood disorder.
Right, G6PD deficiency. Glucose 6-phosphate dehydrogenase deficiency. It's an enzyme defect.
And why does that matter with primaquine? Or pyrimethamine, another antiprotozoal?
Because these drugs put oxidative stress on red blood cells. People with G6PD deficiency, their red cells can't handle that stress because they lack the protective enzyme. The cells basically rupture hemolyze,
Leading to?
hemolytic anemia, which can be sudden and severe, even life-threatening. So screening for G6PD deficiency before starting these specific drugs is a must-do safety check.
All right, let's shift gears. Section 2. Antiprotozoal drugs that go beyond just malaria. What other common infections are we talking about here?
Well, there's amoebiasis, caused by Entamoeba histolytica. Giardiasis, from Giardia lamblia, sometimes get that. Trichomoniasis, a common STI from Trichomonas vaginalis. And toxoplasmosis.
Okay. And you mentioned one that's technically fungal now, but treated like a protozoan.
Yeah, pneumocystis jirovecii pneumonia, or PJP.
Yeah.
Used to be called PCP, often seen in patients with HIV/AIDS. Regular antifungals don't work well, so we still rely on antiprotozoal agents to treat it.
And the big gun in this category seems to be metronidazole, brand name Flagyl. It treats bacteria, protozoa, quite versatile.
It really is a workhorse. It's effective against anaerobic bacteria, plus many protozoa like the ones causing amoebiasis, giardiasis, and trichomoniasis. It even has some activity against certain helminths.
How does it manage all that? What's the mechanism?
It gets into the organism, whether it's bacteria or protozoa, and then it gets chemically reduced, forming these unstable free radical molecules. These free radicals then basically attack the organism's DNA, breaking strands and inhibiting protein synthesis. It leads to cell death.
DNA disruption. Okay. And for that, PJP pneumonia.
We often use pentamidine. It can be given IV or inhaled, like with the NebuPen system. It's directly lethal to P. jirovecii.
How does pentamidine work?
It messes with the organism's energy production by inhibiting glucose metabolism, and it also interferes with nucleic acid and protein synthesis.
So it hits it multiple ways. Is it used for prevention too?
Yes, particularly as prophylaxis in high-risk patients, like those with very low CD4 counts in HIV. There's also atovaquone, another option, usually for mild to moderate PJP. It works by inhibiting mitochondrial electron transport in the organism.
Okay, now for a massive safety alert. Metronidazole. We have to talk about the alcohol interaction.
Absolutely non-negotiable patient teaching point. This is critical.
Yeah.
Patients taking metronidazole must avoid all alcohol, and not just while they're taking it.
Right, the timing is specific.
Yes. No alcohol for 24 hours before starting the therapy, and crucially for at least 48 hours after the very last dose.
And if they slip up, what's the risk?
They can have a severe disulfiram-type reaction. Think of the drug Antabuse, used to deter drinking. Metronidazole can cause a similar effect.
Describe that reaction. Is it just feeling a bit sick?
Oh, much worse than that. Flushing, throbbing headache, nausea, violent vomiting, sweating, chest pain, palpitations, confusion. It can even lead to circulatory collapse in severe cases. It's extremely unpleasant and potentially dangerous.
And alcohol includes hitting sources, too.
Absolutely. You need to warn them about things like liquid cough syrups, mouthwashes, even some sauces or desserts prepared with alcohol that hasn't fully cooked off. They have to be vigilant.
Wow. Okay, that's a huge one. Any other major metronidazole interactions?
Yes, it can also increase the anticoagulant effect of warfarin. So, increased risk of bleeding. Monitor INR closely if a patient is on both.
And pentamidine, is that one gentler?
Not really,
Yeah.
unfortunately. Pentamidine carries significant risk, too. We need to watch patients very closely for adverse effects.
Such as?
Hypotension, low blood pressure is common, especially with IV administration. Cardiac dysrhythmias can occur. It can be nephrotoxic, damaging the kidneys, and also cause blood cell problems like leukopenia. Oh, and patients often complain of metallic taste.
So lots to monitor with pentamidine as well. Okay, let's move on to the worms. Section 3. Anthelmintic drugs. These target helminths, parasitic worms.
Right, and helminths are generally classified into groups. Nematodes, which are roundworms, cestodes, the tapeworms, and trematodes, which are flukes.
And the key thing here before treatment is
Identification. You absolutely need to know which worm you're dealing with, usually confirmed by analyzing a stool sample for ova or parasites. The Antimalarial drugs are often very specific. Using the wrong one won't work and just adds unnecessary drug exposure.
makes sense. Let's look at a couple of examples. Pyrantel, you mentioned it's available over the counter.
That's right, pyrantel, often sold as Pin-X for pinworm infections. It's unique in being OTC in the U.S. It primarily treats intestinal roundworms like Ascariasis and Enterobiasis, pinworm.
And how does it get rid of the worms?
It acts as a neuromuscular blocking agent for the worm. It blocks the effects of acetylcholine at the worm's neuromuscular junction. This causes paralysis.
So the worm gets paralyzed.
Exactly. Can't move, can't maintain its position in the gut, and it just gets flushed out by normal intestinal peristalsis.
Neat. Okay, what about something for flukes or tapeworms?
For many of those, we use praziquantel, brand name Biltricide. It has a broader spectrum against flukes and most tapeworms.
And praziquantel's mechanism, is it paralysis too?
It's different. Praziquantel works by increasing the permeability of the worm cell membrane to calcium ions. This flood of calcium entering the worm causes intense muscle contractions, spasms, and paralysis. But it also seems to damage the worm's outer layer, making it vulnerable to the host's immune system. The worm gets dislodged and is destroyed.
Okay, dislodgement and destruction. Now, is praziquantel safe for everyone? Any major contraindications?
Yes, one very important one. Ocular cysticercosis. This is when tapeworm larvae form cysts in the eye.
Why is praziquantel contraindicated then?
Because killing the larvae inside the eye with praziquantel triggers a massive inflammatory response. That inflammation within the confined space of the eye can cause irreversible damage, potentially leading to blindness. So absolutely contraindicated if the infection's in the eye.
Got it. And any warnings for parental?
Yes, parental is generally well tolerated, but it's contraindicated in patients with liver disease.
All right, this leads us perfectly into section 4, the nursing process. Pulling all this together, what are the essential baseline checks before starting any of these drug classes?
It really depends on the specific drug, but you need a thorough baseline assessment. For chloroquine or hydroxychloroquine, given the eye risks, you need a baseline visual acuity test. Also, check the skin, as they can worsen psoriasis.
Okay, eyes and skin for those. What else?
For mefloquine, definitely that psychiatric history we discussed. For primaquine, you need to know their G6PD status. Baseline hearing might also be relevant for some. And almost universally, baseline kidney and liver function tests are a good idea because many of these drugs are metabolized or excreted through those organs.
And getting samples.
Crucial. Obtain those stool specimens or blood smears for malaria before starting the medication. Treatment can kill the organisms and make diagnosis impossible later.
Okay, assessment done. Now, implementation. How do we give these drugs safely and make them more tolerable?
Well, GI upset is pretty common across the board. So, advising patients to take most of the oral forms antimalarials, like chloroquine, atovaquone, and metronidazole, with food or milk can really help reduce nausea and stomach pain.
Good tip. Take with food. Anything specific about Tauri administration? We touched on metronidazole.
Yes, worth repeating because it's so important. IV metronidazole must always be infused slowly, typically over 30 to 60 minutes, depending on the dose and concentration. Never, ever give it as a rapid IV push or bolus. That can cause severe hypotension and other adverse effects.
Slow infusion for IV metronidazole. Got it. What about patient reporting? What should they watch for?
With metronidazole, specifically instruct them to report any neurological changes immediately, dizziness, confusion, numbness, or tingling in extremities. That could indicate neurotoxicity.
Okay. And one last point on those stool samples.
Yes, collection technique matters. The sample must not be contaminated with urine, water, or any chemicals like from the toilet bowl. These contaminants can destroy the parasites or ova, leading to false negative results. Needs to be a clean catch into the collecting container.
This has been a very thorough deep dive. Let's quickly recap the biggest takeaways.
Okay, so antimalarials need to target the right Plasmodium life stage blood or tissue. Other antiprotozoals like metronidazole often work by messing with the parasite's DNA.
Right, and anthelmintics are often about paralyzing or dislodging specific worms, which means you absolutely need that correct identification first.
And the common thread through all of this is the potential for toxicity, which demands careful baseline assessment, checking eyes, psych history, G6PD, liver, kidneys, and really clear patient education, especially on those critical interactions.
Absolutely. So let's end with that provocative thought, tying it all together. Thinking specifically about metronidazole, what everyday habit must a patient temporarily give up completely?
A habit many people wouldn't even think connects to an antibiotic.
And what potentially catastrophic reaction is the nurse preventing by ensuring the patient understands and follows this rule?
The answer, of course, is avoiding all alcohol intake hidden sources included for that specific time frame we discussed.
That prevent.
That severe, potentially life-threatening desulfiram-type reaction. It perfectly highlights how knowing the pharmacology, the interactions, isn't just academic. It's fundamental to keeping patients safe.
Couldn't agree more. It's about preventing catastrophe through knowledge.
Well said.
Thank you so much for joining us for this vital deep dive today.